the overall takeaway from this paper is that while pituitary adenoma is a highly incident disease, especially relative to the other problems we have in neurosurgery, the vast majority of patients had excellent outcomes with outstanding rates of tumor control and biochemical control. The vast majority of these tumors did not require surgery and were diagnosed either incidentally or from relatively minor symptoms. That's a key takeaway. Incidence is increasing over time for patients, but treatment options have evolved, and the vast majority of patients experience a good outcome. Hi, my name is Nikita Lakomkin. I'm one of the neurosurgery residents at the Mayo Clinic in Rochester. Thanks a lot for the opportunity to talk about the study we published in collaboration with our co-authors here, Dr. Chris Graffio, who is the lead author, Lucas Karlstrom, and Dr. Jamie Van Gompel, who is the principal investigator. Our study is titled Pituitary Adenoma Incidence Management Trends and Long-Term Outcomes, a 30-year population-based analysis. The purpose of this study was to provide an epidemiologic analysis of this patient population over time. Previously, things like disease prevalence were really extrapolated from cadaveric studies or smaller cohorts around the world. No prior study has looked at a series of patients in the United States over a significant amount of time. In this study, our main goal is to look at essentially who developed these tumors, so demographics, how they were found to have these lesions, presenting features, and disease outcomes. We classify this as tumor control, biochemical control, and complications. We found that the vast majority of patients, about 43%, presented with hyperprolactinemia, and over a third, 37% in our series, were found completely incidental, so without any preceding symptoms as part of a workup for another problem. Over a third of patients were treated with simply observation, about 36%, and 37% were treated with medications. So the vast majority of patients never required surgery. What we found in our paper was that the standardized incidence rate increased from about 3.78 in 1989 to 16.87 in 2017, really showing a linear increase in incidence over time. One possible explanation could be that simply the increased use of MRIs increased the proportion of patients who are diagnosed via incidentally, so without any preceding symptoms. But the rate of patients who are identified incidentally actually remains stable over time. So some of those patients who were found to have an incidental tumor still had some element of hormone secretion. And for example, to achieve biochemical control, if it's a prolactinoma, a lot of times those folks will still be treated, since even though they didn't notice that they had those symptoms, it can be of value to achieve biochemical control. Versus, for example, if someone had a non-functioning pituitary adenoma that was found incidentally, and it wasn't abutting the chiasm, it wasn't causing any symptoms or hormone secretion since it's not functioning, a lot of times those can be watched. The average size of the pituitary adenoma diagnosis was about 8 millimeters. In terms of outcomes for patients, the complication rates remain relatively low, with over 95% achieving tumor control. Complications in this case included worsening pituitary endocrinopathy, about 11%. 3% had panhypopituitarism, so dysfunction of all of the hormones that's secreted by the gland. And worsened visual field deficits were found at only 2%. In terms of the other trends that we looked at in terms of treatment, we found that the armamentarium of treatments offered for pituitary adenoma really evolved over time. And this is from both a medical and surgical standpoint. For example, there was a study in the New England Journal published in 1994 showing the benefits of cabergoline compared to bromocriptine. And we saw a trend in change in the type of medication administered over time. In addition, from a surgery standpoint, these tumors were initially treated with a big open craniotomy. And as technology evolved, for example, the operating microscope, microscopic transsphenoidal pituitary surgery became possible. And over the last several decades, with the advent of the endoscope, this has further progressed. And now patients have access to even more advanced imaging and intraoperative treatment as part of an interdisciplinary team for these types of tumors. In terms of next steps, there are a lot of exciting technologies on the horizon. For example, OTL38 and other agents that allow us to visualize tumors of folate receptors, especially corticotrophs, as well as other mechanisms that can facilitate fluorescence-guided surgery, and looking at how these new technologies and new surgical techniques are incorporated into physicians' practice patterns will be important to look at over the next several years. Thank you very much.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.